In this presentation, I'll be talking about white matter diseases and their mimics. Many different categories of diseases can affect white matter. These include vascular, demyelinating, infectious, things like PRES, toxic metabolic etiologies, genetic conditions, as well as tumors that mimic primary disorders of white matter. And we'll go over each of these categories and each individual etiologies in this presentation. As far as imaging techniques, when assessing white matter diseases, MRI obviously is the modality of choice, and in particular, the workhorse of the MRI would be their high-resolution FLAIR images. Now, obviously, minimal for these would be 1.5 Tesla, but 3 Tesla is really increasingly become sort of the standard of care almost for these white matter diseases. Flare is obviously the most important sequence when you're looking at for these white matter diseases as far as detection of the areas of involvement. A 3D acquisition, like shown here, is preferred, but 2D with 3 slice thickness and no gap between your slices is also probably okay. As long as I think preferably you would have axial and sagittal acquisitions because sagittal can really help you see the orientation of some of the lesions for things like MS. Here you have this one image with one series that's a three-dimensional flare series, and you can actually MPR these in any orientation you want, and that's one of the nice things about them. And you can really interrogate, these see these really small lesions that are obviously very characteristic of MS. One thing is with flares, if you obtain these flare images after intravenous contrast, they can show you leptomeningeal enhancement very nicely. And in fact, post-contrast flare is the most sensitive modality we have for detection of a leptomeningeal enhancement. It's not post-contrast T1, it's post-contrast flare. So that's one thing that if you're doing a study with IV contrast, a lot of times flare tends to be done after IV contrast for that reason. T2 or proton density images are actually a nice adjunct to FLAIR, particularly in the posterior fossa, and it's really almost mandatory to look at them in the posterior fossa. Here is an example of a proton density and T2 weighted image showing pretty convincingly this left vermian cerebellar lesion. On the FLAIR image of the exact same position, much harder to see it. If you do, again, this is a 3D acquisition FLAIR, so if you do your MPRs on the coronal plane, you can see here this white matter here. It's supposed to be dark, but it's actually a little bit bright compared to the white matter here. So you can see that there's truly a lesion here, and if you're pretty sharp, you'll be able to pick this up even on flare. But really, the proton density and the T2 show it much nicer and much more convincing and easier to pick up. This particular lesion was actually missed when prospective interpretation of this study, and I think the reason is just nobody bothered to look at the proton density on T2. Now, typically, you'd want T1 both pre and post contrast images when assessing white matter lesions. As far as post contrast images, obviously, enhancing lesions in a setting of white matter diseases typically represent areas of active demyelination or inflammation. For instance, in this particular case with MS, here we have a post contrast T1 and this is a pre contrast. These two lesions, for instance, would be areas of active demyelination in that setting. One thing to note is that enhancement does not necessarily just imply an inflammatory process. Subacute infarcts can also enhance. That's something to keep in mind as well. As far as the pre-contrast T1, in particular spin echo pre-contrast T1s, in the setting of these demyelinating diseases, being lesions that are dark on spin echo T1, and here these two lesions are not dark. You can see there's nothing dark here, so this particular patient does not apply, but dark T1 lesions can represent areas of axonal loss, and that's why it's sometimes nice to have both T1 pre and post contrast. Increasingly, we're obtaining these three-dimensional T1 MP-RAGE images. They're very good as far as volumetrics. They really nicely outline the gray and white matter differentiation. So they're very good for volumetrics and a good adjunct to 3D flare. Sometimes when you're not sure if something's an artifact or not on flare, you can go to the 3D T1 MP range, and you can see if there is also a lesion there. So for instance, here you can see a lesion here, and there's a lesion that has a dark correlate here on the MP range. This particular lesion here has a dark correlation on MP range. And now remember, I told you about spin echo T1 dark lesions being areas of axonal loss. That's just for spin echo images. As far as 3D T1 MP range, they basically show almost every particular lesion. So uh, when you're talking about these T1 dark lesion or black holes, and I'll go over this again, it doesn't make sense to talk about them on MP range. MP range is really just for volumetrics as an adjunct to 3D FLAIR for troubleshooting. It is not for detecting, severe areas of demyelination or axonal loss. A lot of white matter diseases tend to have orbital problems and in particular optic nerve problems associated with them. So it's sometimes can be helpful to get orbital imaging as well. And when you're looking at orbital images, it's imperative that you have some kind of fat suppressed T2 or steer image. This particular case, you don't have any abnormal signal, but this is what a nice fat suppressed image should look like. You have your fat, intraorbital fat, nicely suppressed, very homogeneously suppressed, no inhomogeneity, etc. And coronal tends to be the best plane for looking at the orbits, and in particular the optic nerves. On the axials, you tend to have like slice selection problems a lot of times, but coronal, at least you're going through it, in cross section, so you have a lot more views of optic nerves. And then again, also post-contrast imaging is very important too, and in particular, fat suppression is extremely important. Here you have this person has optic neuritis on the left. You can see enhancement, pretty robust enhancement of this left optic nerve compared to the right. You can see it both on the coronal plane and in the axial plane. And this particular case shows the importance of fat suppression. So this is that exact same case, exact same time. This is the brain MRI that's done without fat suppression. You can see the fat here in the orbit. You cannot tell that this optic nerve is enhancing. I mean, it's basically impossible to tell that this optic nerve is enhancing compared to the other one, versus on the fat suppressed sequence, so clear as day that this optic nerve is enhancing compared to the opposite side. So basically, fat suppression is absolutely crucial for when you're assessing the orbits, particularly for assessment of the optic nerves. So we'll start going over the etiology of white matter diseases, and probably the most common thing you'll see in your any kind of practice is small vessel white matter disease. This is pretty much that white matter signal changes you're going to see as people get older, and you're going to basically see it almost universally as people get older. It's very common, obviously, correlated with age and also vascular risk factors. The typical lesions here will be sort of your frontoparietal lesions. They will involve, periventricular regions, so around the ventricles, and then also the deep white matter, but they won't typically involve the U fibers. So U fibers are those fibers that are immediately deep to the cortex. As you can see, these hyperintensities don't actually reach all the way to the cortex. They sort of stop shy of that immediate white matter before the cortex. Now, these white matter hypertension can also occur in the brainstem and pons, but they'll be very central, as you can see here, and they'll have like a linear look to them going across, kind of like that. They'll be quite symmetric. I mean, not entirely symmetric, but if you have lesions on one side, you tend to have lesions on the other side as well. They might not be the exact same prominence, but they have a similar shape and again tend to be central. Now, if you ever find yourself trying to grade these white matter hyperintensities, I don't find it particularly helpful, but if you wanted to, there are some grading scheme. One of them from this article, for instance, I've highlighted here. They make a distinction between periventricular hyperintensity, so those hyperintensities that are right next to and touching the lateral ventricles, as well as the deep white matter hyperintensities, which are white matter lesions that are not. So for periventricular hyperintensity, they'll have a grading 0 to 3, 0 being absence, 1 being like small caps or pencil thin linings. So for instance, maybe on this side, this would be just a cap or like a pencil thin lining. Two would be like a smooth halo. Maybe this one's a halo for periventricular hyperintensity. And then three being irregular periventricular hyperintensity that extends to the deep white matter. So for instance, this hyperintensity on this other patient, you can see this periventricular, but it's very kind of irregular, and this does extend to the deep white matter. So this would be a 3 as far as the periventricular hyperintensity goes. And then for deep white matter hyperintensity, this particular grading scheme, 0 is absence, 1 is punctate foci. So for instance, things like this and that would be punctate foci. 2 would be beginning confluent foci. I mean, I don't know if I would call this beginning. Maybe these here would be beginning confluent foci right here. So this would be an overall 2 grade for this particular MRI for deep white matter hyperintensity. And then 3 would be large confluent areas. And this particular one, you can see this is the periventricular hyperintensity, and this is some additional deep hyperintensity right here. So this is pretty confluent deep hyperintensity, same as over here. This stuff is all deep confluent hyperintensity. So this would be a 3 for both deep white matter as well as the periventricular hyperintensity. Now, it's good to have a sense of how many of these lesions you should expect and how many people should start getting as time goes on and as they get older. There's some studies. This is one study that looks at this particular topic. One thing to note is these are the numbers and the standard deviations. Like standard deviations are huge. So there's a huge variability in these things. But on average, when you start around 60, you'll have like about 16 or so of these lesions in total. If you add these numbers, it'll be a little bit over 16. But then as the decades go on, if you look at these numbers, roughly 5 new small lesions. This particular study defines small as 1 to 3 millimeters. You get 1 new medium lesion, which they define as 3 to 10 millimeter, and 1 new large lesion greater than 10 millimeters per decade after the age of 60. But this is, again, you see huge standard deviation, but this is a rough estimate. And then you add all these numbers up, add up to about 1 lesion a year on average you're going to get. Now, this actually is kind of an interesting thing because a lot of these people with true white matter lesions, they get their follow-up MRIs on an annual basis. So once they hit the age of 60, just by aging, you expect them to develop some white matter hyperintensity at a rate of roughly 1 a year. So it's like becomes pretty difficult if you just have 1 new lesion, whether your underlying white matter disease is getting worse or if it's just small vessel disease and a result of aging. So that's something to keep in mind when you're reading these older patients. This slice is a little bit old, but I try to have something on clinical significance. And the last time I checked on it, which admittedly was a while ago, the evidence was very mixed. I mean, some studies found weak correlations between these white matter hyperintensities and performance on cognitive tests and things like that. But then some other studies would not find it, especially if they correlated and accounted for things like brain volume, for instance. But if there is an effect between these hyperintensities and anything of clinical significance, it'll probably be a small, it's a small effect, not a big one. So next we'll talk about multiple sclerosis, which is going to be by far the most common non-small vessel white matter disease you're going to encounter. This is the most common of the demyelinating conditions, and probably, in neuroimaging, one of the most common indications for imaging. So this is a demyelinating condition. It's characterized by recurrent attacks of demyelination, and it's got a very perivenular inflammation and demyelination, and axons are typically preserved. It's just a demyelination. But of course, it's not entirely true because in severe disease, you tend to start having axonal loss. Here's some images of a patient with MS, and this is sort of this SWI here showing the perivenular aspect of MS. You can see this white matter hyperintensity that's here and there has a little dark vessel going through it. So that's like what it means by this perivenular inflammation. Now, MS has probably both genetic, environmental, even geographical etiologic factors, but we're not going to go over them in this lecture, or the clinical aspects too much. Women are most frequent, more commonly affected than men, and the age of onset is usually 20 to 40, but really can be at any age. Now, it is crucial that any radiologist know the latest McDonald diagnostic criteria for the diagnosis of MS, and the latest one was in 2017. And in particular, as it relates to imaging, there are two core imaging requirements that, at least based on the 2017 McDonald criteria, do not depend at all on clinical factors. Based on looking at your images, you can say whether somebody meets the dissemination in time core imaging requirement or the dissemination in space core imaging requirement. Now, dissemination in time requires one of these two conditions to be met. So you either have a new T2 lesion or enhancing lesion on a follow-up MRI. Now, this condition one means you have two time points. You have a new T2 lesion or a new enhancing lesion on a follow-up MRI. Or you can have just one MRI and then you have a simultaneous enhancing and non-enhancing. So this "and" is important. You have to have both enhancing and non-enhancing. You can't have all lesions be non-enhancing. At the same time, you can't have all lesions be enhancing either. So if you want to meet the dissemination in time criteria, you can do so with just one MRI, but it's just that one MRI need to show you both enhancing and non-enhancing lesions. The second core imaging requirement is dissemination in space, and that requires you to have just one lesion in two of these four areas. And we'll go over what these areas are because these have very specific definitions, with the exception of spinal cord. We'll talk about that in our spinal cord lecture. But these areas are periventricular, juxtacortical, infratentorial, and spinal cord. And it is crucial that any radiologist know what these things mean. And in particular, periventricular and juxtacortical, infratentorial, and spinal cord are pretty self-explanatory. Now, one thing to note is just meeting the core imaging requirements does not equal MS. MS cannot be diagnosed based just on imaging without clinical attacks. And then how much clinical attacks you need and how to actually diagnose MS is not something we as radiologists concern ourselves with. We as radiologists need to be able to tell whether it's dissemination in time and dissemination in space. So we don't diagnose MS, we just tell clinicians whether it is dissemination in time or dissemination in space. Now, McDonald criteria does actually define what a lesion is for the purposes of MS, and they define it as an area of hyperintensity on either T2 flare or proton density image that's at least 3 millimeters in the long axis. So in any axis, it needs to be 3 millimeters or more. So that's basically how it's defined. If you have these like little dots of hyperintensity for the purpose of McDonald's criteria and the initial diagnosis of MS, those things do not count as lesions. So they need to be at least 3 millimeters in their long axis. They could be very thin, but as long as they're 3 millimeters in long axis, that's okay. So a lesion like this is okay. I mean, it's probably thinner than even maybe 1 millimeter, but it's long and at least 3 millimeters here. So that lesion would count as a quote unquote lesion. Now they're typically going to be ovoid like these or flame shaped, kind of like that. And some typical regions, obviously we have the McDonald criteria, but in periventricular region, they give you that Dawson's finger appearance, sort of like this. It's starting to go from the ventricle towards radiating out from the ventricle. These lesions here, they all sort of have that, their orientation seems to be going away and sort of perpendicular to the ventricle. So that's what Dawson fingers are. Now, corpus callosum, like this particular lesion here, are pretty common sites, as are the callososeptal interface, so on the surface of corpus callosum where the septum pellucidum is. Now, optic nerves is a pretty common site of involvement, and again, we talked about orbital imaging a little bit, but one thing is, at least in McDonald's criteria, optic nerve involvement is not like considered an imaging requirement for MS, and it doesn't add to any of those regions or things as far as McDonald's criteria go. And again, posterior fossa and spinal cord are also common locations for MS lesions. All right, so now we'll go ahead over the definition of those different regions as far as McDonald's criteria go. So first, periventricular lesion. It's defined very precisely as lesions that abut the lateral ventricles without white matter in between. Abutting, so you have to actually touch the ventricle. It doesn't, like this lesion here, this is not a periventricular lesion. It's close, but it doesn't touch it. So this is not a periventricular lesion. but this lesion here is a periventricular lesion because it abuts the lateral ventricles. Now, this includes corpus callosum lesions, kind of like here, and these lesions here, this corpus callosum lesion, but touches the ventricle, as you can see. This is a corpus callosum lesion, touches the ventricle, as you can see, but they exclude lesions in the deep gray. So if you had a lesion in, over here in the caudate that touches the lateral ventricle, that's excluded. And then these are the lesions that give rise to your Dawson's finger appearance. And here is another like periventricular lesion. Don't forget that the temporal horn of the lateral ventricles kind of is here. So a lesion that touches the temporal horn right here, that would also be a periventricular lesion. So it's very important that you use periventricular term very precisely and not loosely, because sometimes people use it very loose. Any lesion that's close to the ventricle you call periventricular. That is incorrect for the purposes of MS. For the purposes of MS, a periventricular lesion, when you talk about it in your report, you have to mean abuts the lateral ventricle and not even the third ventricle, the lateral ventricle. And obviously, third ventricle lesions that touch the third ventricle tend to be in the thalamus, and deep gray are excluded anyways. But lateral ventricle and abutment, very important to remember. Here I'm just emphasizing that again to exclude the lesions that do not touch the ventricles. For instance, this thing here, this thing obviously is a thalamic lesion and it also doesn't touch the lateral ventricle, so it misses that criteria by 2. And then these are a bunch of other tiny lesions here you can see that are sort of far away from the ventricle, so that don't actually touch the ventricle. Now, that being said, McDonald criteria also exclude the symmetric hyperintensities, posterior or anterior. So, these lesions here, like this sort of symmetric linear hyperintensities, these are also excluded sort of by definition by McDonald. And this particular patient was just a microvascular ischemic patient. So, these hyperintensities, they're technically periventricular, like they abut the lateral ventricles, but because they are symmetric and because they are sort of linear, either symmetric or linear, they do not count as periventricular lesions for the purposes of diagnosing MS. So, and even if you had just symmetric only anterior or symmetric only posterior, they are also excluded. So, just things that look like chronic microvascular ischemic change, even if they touch the ventricles, they're excluded. But again, they have to be symmetric or they have to be these linear hyperintensities. If they're asymmetric, if it's just around one horn of the ventricle and the other horn is clear, you can count that as a periventricular lesion for the purpose of MS diagnosis. All right, so now what is a juxtacortical lesion? The definition of juxtacortical by McDonald's is a lesion that abuts the cortex and is not separated from it by white matter. So here's a couple examples of juxtacortical lesions. Here you can see this juxtacortical lesion. This is a hyperintensity, clearly touches this cortex right here. And then here is a hyperintensity right here. This is the hyperintensity here, clearly hugging along that cortex. These juxtacortical lesions, they're because they're touching the cortex, they don't tend to be these round lesions. So if you see a round lesion that you're about to call juxtacortical, think twice, because these lesions, they tend to really go along with the cortex. They will have like a comma shaped appearance almost, they kind of, or a semicircular appearance because they're hugging that cortex. Like for instance, lesion like this, this particular lesion, I would not call this juxtacortical because it does have a like sliver of white matter between it and the cortex. This lesion even here, I wouldn't call it juxtacortical because it has this sliver of white matter between it and the normal cortex. But this particular lesion, you can call a juxtacortical. And again, this is that same case as this one. And then this lesion, you see on axial, if you have traditional, flare, much harder to say that it's a juxtacortical lesion because the cortex is not very well defined on these thick section images. But on these thin section volumetric images, nicely you can see at multiple slices that it's sort of hugging along that cortex and it's a clear juxtacortical lesion. Now, infertentorial lesions are lesions in the brainstem and cerebellum, including the cerebral peduncles. So here are some examples of brainstem cerebellar lesions. You can see here this lesion involving the middle cerebellar peduncle on the right, and you can see these are sort of very asymmetric. Those as microvascular ischemic white matter lesions in the brainstem are very symmetric. They're sort of central and they go linear almost. This is very asymmetric hyperintensity. Here are some enhancing lesions in the brainstem and cerebella, and here's the lesion we talked about when we discussed the proton density and T2 weighted images. So it's good to talk about contrast enhancing lesions in the setting of MS. So the presence of contrast enhancement reflects a breakdown of the blood-brain barrier as a result of active inflammation. It's good to know the average duration of these is about 3 weeks with a median of about 2 weeks. And a very small fraction of lesions remain enhancing more than 10 weeks in this particular study. So if you see a lesion that's persistently enhancing after 10 weeks, you got to think twice about whether that's truly an MS lesion. Sometimes it can be, but a lot of times it's not. There's some other explanation for it. I've seen things like capillary telangiectasias be mistaken for like a persistently enhancing MS lesion, subacute infarct sometimes be mistaken for MS lesions, etc. So just remember the average duration of the enhancement and the median is 2 to 3 weeks. So anything after that, you start to be a little bit suspicious. As far as the enhancement pattern, people like to talk about this sort of open ring enhancement pattern, and you certainly see that, but you can see true closed ring enhancement pattern like these. You can see like punctate enhancement patterns like this. This particular case, if you want to scroll through, has a number of enhancing lesion, multiple, and they basically look like anything they want to look like, honestly. But the incomplete ring enhancement is considered the classic sort of MS enhancement, but don't think that small lesions they can enhance like whatever they want, however they want, and even the larger lesions sometimes they can homogeneously enhance. Again, it doesn't necessarily rule MS out or anything like that. Now, I briefly alluded to this when I was talking about imaging technique, but in the setting of MS, you can have these things, the T1 hypointense lesions. These are lesions that on your spin echo images, T1 images obtained before contrast, they're actually dark, like this lesion here, for instance. This particular lesion here, it's we can window this a little bit better, and you can see, yeah, this particular lesion is nice and dark here. So these are the so-called black holes. I think probably the better term is T1 hypointense lesions. I don't like to use the term black hole, but that's something that's colloquially they're referred to. Again, very important to remember that they're truly based on spin echo, not based on MP-rate. So do not go around talking about black holes or T1 hypointense lesions based on MP-rate. If you talk about it, as I showed in that image with the flare and MP-rate side by side, you can pretty much see all lesions on MP-rate. So that basically becomes meaningless to talk about T1 hypointense lesions on MP-rate. Now, these lesions, important to know that they can actually be non-specific. Just seeing a lesion be T1 hypointense, it doesn't necessarily mean that it's due to axonal loss, although that's typically what you think of when you see these T1 hypointense lesions. These are areas of severe demyelination and loss of axons, so the axons aren't coming back. But it can also be seen in the setting of partially remyelinating plaque, in which case the hypointensity would resolve with time. And there's a couple of studies looked at that and published on that. Some of them even had like histologic correlates for some of these that they could actually see remyelination in these intrinsically T1 hypointense lesions. So when you have the persistent T1 hypointense lesion, that's what most people refer to when they really talking about these black holes or those persistent T1 hypointense lesions. Those are markers of severe demyelination with axonal loss. And the degree of signal intensity may be related to the axonal loss, and importantly, the total volume of these T1 hypointense lesion has a much better correlation with your disability score as a result of MS compared to things like FLAIR. And in fact, in MS, there's this condition of like clinical imaging dissociation where the FLAIR sort of volume of FLAIR lesions doesn't quite correlate with clinical disability, but these T1 hypointense volume does correlate a lot better with your disability scores as a result of MS. So that's what makes talking about these T1 hypointense lesions meaningful, the fact that they have a better correlation with clinical features and clinical disability. And again, that's based on spin echo imaging. Again, if you talk about these based on MP-RAGE, you don't have that correlation anymore, so it's meaningless to talk about them. So just remember, when you're talking about T1 black holes, they can be transient. So we're talking about just persistent T1 hypointense lesions, and those persistent T1 hypointense lesions are markers of axonal loss. So here's an example case of a transient T1 black hole. So here you can see this is time point 1 on the top row, and then time point 2 a while later on the bottom panel. So here this patient had this nice intrinsically T1 hypointense lesion here that was pretty nicely enhancing. You can see it here, had a little bit of edema. So this was an actively demyelinating lesion at this time point. There's another T1 black hole here that was also actively demyelinating at that time. And on the subsequent study, you can see this T1 hypointense lesion now just a tiny dot may be left of it. And you can see it shrunk up nicely even on the FLAIR image. And this other T1 hypointense lesion is like gone basically. So these particular ones, I mean, if there were true axonal loss, I mean, axons, they're not going to come back in an adult, so they should have stayed persistently T1 hypointense. But the fact that they've gone away for the most part and only a dot left for one and the other one completely gone away, that just means that these were transient T1 hypointense lesions, in which case they were just areas of remyelination. So these would not be so in the setting. So then on this image, you should not have interpreted these T1 hypointense lesions as areas of axonal loss, because clearly they were not. Uh, since becoming aware of the fact that these T1 hypointense lesions can be transient, I've only really encountered them in the setting of enhancing lesions. So just my 2 cents are, if you see an enhancing lesion that's also T1 hypointense, doesn't mean anything. It's just you got to see what it looks like on the follow-up studies, if it really is areas of axonal loss or not. Now, something that's different from T1 hypointense lesions are actually flare hypointense lesions. So again, lesions of MS are typically all of them, even the T1 hypointense lesions I showed you before, they're actually flare hyperintense, or they're bright on flare. Now, when you have lesions like this, and this particular patient with MS that are actually dark on flare, they'll still be bright on T2, but they're dark on flare. That just means they're starting to become replaced with CSF. So they've like such profound loss of white matter that they're starting to be vacuolated and replaced with CSF. So this is like a much higher correlation with like clinical severity and stages of the disease and chances of secondary progressive MS based on this particular study. So this is just something I want to show, so you're aware that you can sometimes see these flare dark lesions, and those are typically correlated with more clinical severity and also secondary progressive forms of MS. Now that I've talked about MS, we'll talk about tumefactive demyelinating lesions. So tumefactive demyelinating lesions are basically just large demyelinating lesions, sort of arbitrarily defined, greater than 2 centimeters. They can be solitary or few in number, and they're just by tumefactive, I mean, because they're large and they tend to be enhancing and angry looking, they tend to be mistaken for tumors. Some of the features that would clue you in that you're dealing with a tumefactive demyelinating lesion is that incomplete ring of enhancement. Like you can sort of see it here. There's like an incomplete ring. The ring is complete here, but right here on this side is an incomplete ring of enhancement. Paucity of edema compared to lesion size. So for instance, this lesion, if this was a glioblastoma, I mean, you would have tons of edema surrounding it. But here, this particular lesion, not a lot of edema around it, and also not much mass effect. I mean, you can see, there's some edema around it, sure, but it doesn't really efface this. So you can see the sulcus so nicely preserved, like the sulci are nicely preferred. This was a glioblastoma compared to its size, you would have a lot more mass effect. So these are some of the features you can see with tumefactive demyelinating lesions. So the incomplete rim of enhancement and paucity of edema and also mass effect. These lesions, they can diffusion restrict. As you can see here, there's an ADC, and you can see the enhancing ring part of it is actually restricting, as you can see here. Now, one thing that you should be aware of is actually non-enhanced CT has a pretty good role for in the evaluation of these tumefactive demyelinating lesions. and distinguishing them from tumors, because these lesions, they always have low attenuation on CT compared to tumors, which tend to have higher or iso attenuation. So, based on this particular study cited on the bottom, if you actually have hypoattenuation of MR enhancing lesion, your accuracy in distinguishing between a demyelinating lesion and a tumor increases to 97% versus just 73% if you only use the MRI features. Here's an example I had of a tumefactive demyelinating lesion. Here, this particular lesion doesn't have a, your classic incomplete rim enhancement, but it does have all the other features. Like this, I would not lead with a tumor because, given its size, if this is a glioblastoma, it should have tons and tons of edema around it, but it has very little edema. And again, if this is an enhancing tumor like this, and it was a tumor, it has to be glioblastoma, basically. I mean, it's not a low-grade tumor. Low-grade tumor wouldn't enhance this much. So if this was a glioblastoma, you would have tons more edema, but you don't. Here you can see on this CT, this lesion is completely dark. There's no hyperintensity associated with that lesion. So this would be a very good sign that this is a sort of a tumefactive demyelinating lesion. And this, in fact, was. This, a couple months later, this shrunk up all by itself. So that's a just remember the role of non-contrast enhanced CT. A lot of times you won't get it, but if you do have it, take a look, and if it's dark all the way through, you can be pretty confident that you're dealing with a tumefactive demyelinating lesion, not a tumor. Now, along the same vein as those tumefactive demyelinating lesion, you have this thing called Balo's concentric sclerosis. It's thought to be a variant of MS. Initially, it was described as this really fatal form, but really all cases of it that I've seen have been very self-limited cases. And a lot of these cases eventually end up meeting the diagnosis of MS. And the feature and highlight of the Balo's concentric sclerosis is these multiple rings that tend to be seen with these demyelinating lesions. And sometimes they give an appearance of like an onion ring, if you will. So here's a nice case. You can have you have the flare here and the post-contrast T1 here, and you can have multiple rings. Here you have a first dark ring, then there's an enhancing ring here, then you can see a thin non-enhancing ring, and then one more enhancing ring around it. See it on the flare too. One non-enhancing center, enhancing thick ring, and then there's a non-enhancing, or I should say non-hyper intense dark ring, and then a hyper intense light ring around that. So it's like an onion skin type of appearance. Here's another case, on the T2, you can see a lot nice, very nicely, these like alternating rings of non-enhancing white matter. You can see here, these alternating rings of non-enhancing, giving that onion skin appearance. On the post-contrast, they sort of tend to blend in, but you can still see some non-enhancing rings. This one's much harder to see, but, on the T2, this one's a nice one as well, because you can see all these hyper intense rings. So that's what Balo's concentric sclerosis is. Again, in my experience, the ones that I've seen have all been pretty much self-limited, resolved with standard, steroid therapy, etc. Right. Next, we'll talk about neuromyelitis optica, as well as neuromyelitis optica spectrum disorders. So this is also amongst the demyelinating conditions, similar to MS, and it's unlike MS though, it is characterized by an antibody against this aquaporin 4 water channel that happen to be in the central nervous system, typically surrounding the ependymon. This also affects women much more than men, and much more so than MS. And then up to 90% of them have a recurrent course, and the relapses tend to be more dramatic than MS. Now, as far as neuromyelitis optica itself, not the spectrum disorder, but neuromyelitis optica itself, it consists of myelitis, optic neuritis, and a positive NMO IgG. And that's just NMO IgG is just the antibody against aquaporin 4. So the classic neuromyelitis optica doesn't really even include brain lesions as part of it, but it's increasingly recognized that brain lesions are also a part of neuromyelitis optica, both just neuromyelitis optica as well as the neuromyelitis optica spectrum disorders. So the main features as far as imaging though that you should remember for neuritis optica are the long segment optic neuritis as well as the longitudinally extensive myelitis. Now the spinal cord stuff is very important part of neuritis optica, and we'll talk about that in the spinal cord diseases lecture. But there's also the optic neuritis aspect. So here you can see a case of optic neuritis in the setting of neuromyelitis optica. You can see the left optic nerve is both enhancing compared to the other side, and it's T2 hyperintense compared to the other side. Now, as we talked about, the hallmarks of neuromyelitis optica are going to be the longitudinal extensive myelitis and optic neuritis. However, it's increasingly being recognized they can also have associated white matter lesions in the brain. Now, the thing to remember as imagers when you talk about NMO white matter lesions are these two terms, periependymal and areopostremia. Now, periependymal refers to the fact that the white matter lesions in NMO tend to be around the ependymal lining of the ventricular system, and that could be any part of the ventricular system. It could be the lateral ventricle, the third ventricle, around the cerebral aqueduct, around the fourth ventricle, and even the fourth ventricular outflow tracts, as you can see here. So for instance, here are some examples of periependymal lesions. You have here the fourth ventricle. There's lesions around in the pons surrounding that fourth ventricle, as you can see here. Now, these cases, I should mention, are all simulated cases because I didn't have a good case to demonstrate these, but they do a good job of demonstrating the fact that they are periependymal lesions. Here's another periependymal lesion in the around the cerebral aqueduct. Again, the aqueduct's part of the ventricular system, so it will be lined by the ependyma, and you would have this lesion would be counting as a periependymal lesion. And then finally is the areopostremia. That's the dorsal medulla, and that's a typical location again for NMO. And that's what's shown here, right here. And this is the medulla, and is the posterior aspect of it. So that's areopostremia. Technically, areopostremia is going to be typically also periependymal because this is like the outflow tract of the fourth ventricle, and so this is also it does in fact qualify as periependymal lesion as well. So I would use these terms specifically when I'm dictating these cases. So whenever I see a lesion setting off classifying a white matter lesion, if I see that lesion touching the ventricular surface, I would call it periependymal lesion. So if I had like a thalamic lesion and it was touching the third ventricle, I wouldn't call it periventricular because in the setting of MS, as we talked about, periventricular means abutting the lateral ventricles. However, I would use the term periependymal lesion because it is touching the ependymal lining of the ventricles, and that term implies to the neuroimmunologist that what I'm trying to say, this patient could have a possibly NMO. Now, it's important to know that in setting of NMO, there is now a consensus diagnostic criteria. Now, classically, NMO, as I said, was just that antibody to the ACO4 and 4 plus long segment myelitis plus optic neuritis. However, that definition has now been extended to include these things called NMO spectrum disorders, which really look like NMO, but they just don't have that antibody. And there are now consensus diagnostic criteria that are now available. I'll put a link here for it for you guys here. It's good to take a look at it because this particular paper, and you can always look for this paper, just Google NMO criteria 2015. It's very, the criteria themselves are not something you should concern yourself with because it's a really complex interplay of symptoms, clinical symptoms, and imaging requirements. So it's not really feasible for us as radiologists to know exactly what their symptoms are and what imaging requirements you have for each of those symptoms. But being familiar with the imaging appearance, and this paper does a nice job of showing a lot of images of what's considered NMO typical lesion. It's good to have that in your mind, especially when you're dealing with a case that possibly is NMO. The summary of it obviously is the areopostremia and the periependymal lesion. So if you include those nice terms in your reports, I think you do your neurologist a good favor. Here's an additional article here that's a radiographics article, and it's also got a lot of nice images of NMO, so you can supplement the images in this presentation. Next, we'll talk about MOGAD antibody diseases, or short for MOGAD. So this is another demyelinating condition that's characterized by an actual antibody, but instead of being the antibody against ACO4 and 4, this one's against MOG, which is the myelin oligodendrocyte glycoprotein. And this is really was originally one of those NMO spectrum disorders. It kind of looked like NMO, but then they discovered that that got associated with this MOG antibody in patients. Now, the clinical presentation of MOGAD is a little bit different from NMO. The most common presentation is actually optic neuritis. So this is really a predominantly an optic neuritis problem. It's often the isolated presentation in about 61% of the cases. One unique thing about MOG is it's very frequently bilateral at its presentation, anywhere in the literature from 29 to 73%. And more characteristically, there's a lot of optic swelling, more so than other causes of optic neuritis. And then it's supposed to be pretty anterior predominant, anterior nerve predominant, meaning it'll be just the orbital and canalicular and not extend so much to the sort of prechiasmatic, chiasmatic, or optic tract portions of the nerve. Now, this particular case of MOG-related antibody disorder actually violates this particular thing. It is very swollen, as you can see. This optic nerve, this left prechiasmatic optic nerve, much more swollen than this right one over here, and the enhancement is pretty robust. But it is sort of posterior nerve involvement. It's sort of the prechiasmatic optic nerve extending here to the chiasm. So the location of the optic nerve enhancement really I haven't found very helpful, even though people publish on what one MS being more anterior, NMO being more posterior. I don't really find that very helpful. But the swelling tends to be pretty prominent in MOG antibody disorders. After optic neuritis is usually myelitis is the most common presentation, and then other forms like encephalitis and brainstem syndromes are after that. This particular article actually sort of enumerated phenotypes at onset for MOG-related antibody disorders. And again, as you can see, optic neuritis was about 60% of the cases, followed by myelitis at about 20%, optic neuritis plus myelitis another 7%. So you already put these together, 90% of cases of MOG antibody diseases present with a combination of optic neuritis and myelitis. So the brain stuff in MOGAD are really sort of more rare as far as initial presentation go. After these optic neuritis and myelitis, then brainstem and the rest, or encephalopathic syndromes and things like that, become more common. Now we'll talk about spinal cord abnormalities in MOGAD in the spinal cord lecture, but in the brain, actually, over 50% of the time, the brain of patients with MOGAD is going to be normal. But when they do have lesions, they tend to be sort of more ill-defined as compared to MS. Like you can see here, this lesion involving the right cerebropeduncle, it's much more ill-defined. You can see it's pretty diffuse. Like if you look at this cerebropeduncle here compared to this cerebropeduncle right there, this is pretty bright, but it's sort of more widespread, not quite well defined, sort of has a fluffy look, etc. Locations that tend to be more characteristic for MOCAD are the juxtacortical location, like this one here. This lesion you can see is juxtacortical. It's like hugging along that cortex right here, this particular lesion. And then also brainstem tends to be other common sites for MOG antibody disorder. Lesions. And then another thing that happens in MOGAD more so than other diseases is that these lesions with time tend to, like, a lot of the times, almost half of the times, like, tend to fully disappear on follow-up, and that's something that you don't really see with other demyelinating diseases. With MS, for instance, lesions can become substantially smaller, but you usually see a remnant of the lesion on follow-ups, versus with MOGAD, a lot of times they actually fully go away on follow-up. And then MOGAD, as you often can see leptomeningioid enhancement. So here's an example of MOGAD that I've had from my case file. Here's time point 1, here's time point 2. So you can see in time point 1, you've got this brainstem lesion involving the right cerebral peduncle and then going all the way to the right aspect of the brainstem. There's some enhancement. You can see the enhancement and the lesion itself, they're kind of pretty ill-defined, sort of fluffy looking, not quite what you would expect with MS, with those round ovoid flame-shaped lesions. Then I'm just showing here for the sake of the follow-up. On the follow-up image, you can see that particular lesion here involving the pons. It's like pretty much gone. You don't even see any hint of it. Here's a T2 image, maybe just a tiny bit of a hint of it in the cerebral peduncle remaining. But there's now this new lesion in the right cerebral white matter. And again, it's sort of fluffy, not very well defined, unlike your typical MS lesion. And the enhancement associated with that lesion is also sort of pretty ill-defined and sort of fluffy looking. So these are some of the lesions you can see with MOG-related antibody disorder. Next up is ADEM, or acute disseminated encephalomyelitis. ADEM is another one of the demyelinating conditions. Now, unlike all the other ones, the MS, NMO, and MOGAD that I talked about, ADEM is characterized by being a monophasic disease, meaning that you get it once and then it doesn't recur. All the other diseases I showed you guys so far, they're all characterized as being these recurrent diseases. You have multiple, you have one event and then you have multiple recurrences of that event occurring. Now, ADEM you typically see in children after an infection or potentially vaccination, but it can also occur in adults, but it's much more typical in children. The underlying pathogen not always identified, and it may follow some non-specific upper respiratory tract or GI tract infection. And then common clinical manifestations would be encephalopathy, sometimes fever, headaches, seizures, focal neurologic deficits, or meningeal signs. Here's a particular case of ADEM. You can see the lesions of ADEM tend to be much more sort of pronounced and ill-defined as compared to things like MS. They do share some similarity with MOG in that they sort of tend to be juxtacortical, sort of ill-defined lesions. So you can see here some lesions form with the brainstem, again, pretty larger and not as quite as well defined as your MS lesions. So as I already alluded to on imaging, ADEM tends to have these rounded, larger lesions with poorly defined margins compared to MS. They can have diffusion restriction and enhancement, and they can involve more or less any part of the brain. The subcortical white matter, the cortex, deep gray, they're all commonly involved. Here's another case of ADEM that I have. You can see ill-defined involvement of your thalamide, the internal capsules, some subcortical white matter involvement that's again sort of pretty ill-defined, unlike what you see in MS. MS, you don't typically see these kind of, more uh, confluent appearing lesions as you see in this ADEM. And here's some lesions involving the cerebellar, middle cerebellar peduncles on both sides. So again, the lesions tend to be more sort of ill-defined. And the trick to these is they're monophasic usually. And what that sometimes translates to in imaging is you're not going to have a situation where some of them are enhancing, some of them are not enhancing, like you see with MS. They'll be typically almost always, or they'll typically be either all enhancing or all non-enhancing lesions. Now, one thing to know about ADEM is that in the pediatric population, there's actually a consensus diagnostic criteria, and I've put in the article that has that consensus diagnostic criteria. And the thing to know about it is that they do include brain imaging as part of the diagnostic criteria, and these are sort of the conditions they think should be seen on the brain MRI. You should see these diffuse, poorly demarcated, and large lesions involving predominantly cerebral white matter, and that deep gray matter lesions can be present. And then T1 hypointense, they say, are pretty rare. So again, those T1 dark sort of black holes, you're not going to see so much in ADEM, which goes with ADEM not being as a result of axonal loss, because it's a monophasic illness and they sort of go away after the acute event. Now, this is a disease that's sort of related to ADEM called AHL, or Hurst disease, acute hemorrhagic leukoencephalitis. It's an aggressive form of ADEM. It sort of typically tends to be fulminant and goes to death in a few days to weeks. It's going to be pretty similar to ADEM, but the key difference is really hemorrhage. So with AHL, H stands for hemorrhagic. So, you're going to have some hemorrhage in AHL. I didn't really have a case of AHL, but if you see something that looks like ADEM and has got a few hemorrhage, you can include AHL or Hurst disease in your differential diagnosis. But I'll have a case of a mimic that would sort of look like ADEM with hemorrhage, and that's a mimic. So it's not really specific at all, and having some hemorrhage in the setting of something that looks like ADEM, but that's what Hurst disease would look like. Next, we talk about PML or progressive multifocal leukoencephalopathy. Now, this is an infectious process of the brain. It's due to reactivation of the JC virus, and almost always in the context of some cellular immunodeficiency. JC virus itself is very ubiquitous, like a majority of the population actually has this virus, but it sort of stays dormant, doesn't cause any problem. But when your cellular immunity gets impaired, it can cause big problems in the form of this PML. As I said, exclusive almost to the immune suppressed. You can see it in AIDS, lymphoproliferative disorder, organ transplant, as well as people who are on immune suppressant. And the classic situation is actually in the patients with MS who are on this drug called natalizumab or Tysabri. That's like the classic situation. But really, PML has been reported in the setting of any sort of immune suppression like methotrexate, steroids, etc. Now, sort of the pathology, you would see, the JC virus infected oligodendrocytes, and then there'll be some demyelination interspaced in that infection. Now, as far as detecting it without histopathology or biopsy, which is obviously ideal, the mainstay is CSF PCR. So if you see it on PCR in the CSF, it's very high in specificity, 92 to 100%. Sensitivity tends not to be as good because a lot of these PML cases are in AIDS people, and the sensitivity tend with better and better antiretroviral therapies, the sensitivity of detecting JC virus becomes lower and lower in CSF just because you won't get as high of a load as you used to before effective antiretrovirals in the CSF, even in the setting of developing PMLs. So here's a particular case of a PML where you have this sort of pretty juxtacortical lesion, very confluent looking lesion as compared to most of the lesions we saw before, and it's sort of not enhancing. So as I alluded to, the imaging features in PML is the highlight is confluent asymmetric juxtacortical lesions. And juxtacortical lesions are lesions that obviously touch the cortex, and another way of saying that is that they involve these things called U fibers. U fibers being white matter immediately deep to the cortex that sort of communicate between different parts of the adjacent cortex. Now, so there'll be confluent juxtacortical lesions. They'll have very little mass effect given the size of the lesions. And the classic situation is that there's going to be no contrast enhancement. However, in 10% of all cases of PML, you're going to see contrast enhancement. So that's not like a universal thing that you'll see no contrast enhancement. But also more importantly, you can see contrast enhancement in the setting of immune reconstitution inflammatory syndrome, meaning PML typically occurs in the setting of some immune deficiency, and then once you take the immune deficiency away, be it you reinitiate antiretroviral therapy or AIDS, or if they're MS on natalizumab, you take natalizumab away, then once the immune system reconstitutes, you start having the enhancement. Here's a particular case showing that this patient has PML. You have these very confluent juxtacortical lesions, pretty asymmetric looking, and they really don't have much mass effect. Like you see here, this sulcus right here, even though this lesion is so big, that sulcus looks very much symmetric to the other side sulcus, so very little mass effect. But in this particular case, they also have some enhancement associated with them, as you can see, sort of diffusely throughout the, the areas of signal change. So just to reiterate this case of PML occurring in the setting of MS and in particular natalizumab, increasing the risk. It's important to know that these people with MS, they get routine follow-ups, and it is not uncommon for them to have asymptomatic PMLs on a routine follow-up. And this particular article looks at this issue, and they discovered that these asymptomatic PMLs in the setting of MX were only prospectively detected about 33% of the time. So we need to, as radiologists, do a better job trying to detect these cases of PML when they're just in routine follow-up. They're not always going to be symptomatic, or the history is not always going to say, oh, concern for PML, things like that. And what distinguishes PML again from routine lesions of MS is that they're juxtacortical. Obviously, juxtacortical lesions are a big part of MS as well, but the MS juxtacortical lesions tend to be small, and there won't be these confluent lesions that you see in the setting of PML. So again, if you see a new juxtacortical lesion that looks very confluent and big, keep PML in the back of your mind. And then if you look a little bit into the chart and you see that patient's on natalizumab, probably the better part of valor is for that patient to get a CSF and get checked out for whether there's JC virus in their CSF. In this particular study, the asymptomatic PML cases were overwhelmingly frontoparietal. This is a case I had of PML in the setting of MS, and this particular case obviously is not. This is pretty occipital involvement, but you can see the difference here. This is sort of very juxtacortical, but pretty confluent looking. If you scroll up, you see some more sort of typical looking sort of ovoid shaped MS lesions, but and then this is like a juxtacortical lesion of MS, pretty small looking, pretty small. And you compare that with this very confluent occipital lesion that's due to PML. Next disease we'll talk about is HIV encephalopathy or AIDS dementia complex. Now, the main findings in HIV encephalopathy are going to be atrophy out of proportion to the patient's age, as well as a very symmetric periventricular and subcortical white matter hyperintensity that spares the U fibers, so it would not be juxtacortical in MS jargon. Now, for all intents and purposes, the appearance is going to be very similar to age-related chronic microvascular ischemia, with the exception that these patients will be very much younger and they would have HIV or AIDS. So here's a case of somebody with HIV. It's a younger patient, but they have these symmetric periventricular white matter hyperintensity. Some of them is subcortical white matter. And as you can see, some of the hyperintensities do go towards the cortex and the subcortical white matter, but they don't actually touch the cortex. So they are sparing these U fibers. So that's kind of one of the hallmark features of HIV encephalopathy. Again, that's also true of chronic microvascular ischemia, and you really can't tell these two apart, just age and the history of the HIV. So next we'll talk about viral encephalitides, and in particular HSV1 being the most common in adults. So HSV1, has a big affinity for the limbic system. And what's the limbic system? Limbic system includes the anterior medial temporal lobe. It includes the insula, as well as the cingulate gyri and the inferior frontal lobes. So here's a particular case of HSV encephalitis. You can see here it involves the mesial temporal lobe, the medial aspect of the temporal lobe, and the hippocampal formation, anterior temporal lobe, and then the insula to an extent is also involved. As you can see here, the insula is somewhat involved. If we scroll up here, you can see the involvement of the insula and some involvement here of the cingulate right there on the right side. Now, this particular case, if you look closely, you'll see this big pachymeningioid hand, and this was a post-operative case. So this patient had just had a surgery here, I think for a schwannoma resection or something. So having a lot of pachymeningio post-operative enhancement, but in that setting of post-operative conditions, developed HSV1 encephalopathy. One thing, as we'll talk about briefly, HSV encephalopathy, you tend to have a lot of diffusion restriction, and this particular case doesn't really have much in the way of diffusion restriction. As you can see, there's a lot of facilitated diffusion. They're not dark, these particular areas of involvement, as you can see. But it's considered typical for HSV encephalitis to have a diffusion restriction. So here we're just going to reiterate the findings of HSV encephalitis. So you're going to have T2 flare hyperintensity in the involving predominantly the limbic systems, and not necessarily all of them, but tends to be in the limbic system. Here you have some hyperintensity in this case involving the medial temporal lobe, the hippocampal formation, as you can see going here. That's a hippocampal formation, the insula in this particular case. Here a little bit of a medial thalamic involvement as well. Diffusion restriction tends to be pretty common with HSV and tends to set it distinct from other viral encephalitides. Here you can see that medial temporal lobe involvement. There's high WI signal and restricted diffusion on ADC. And there tends to be sometimes hemorrhage. This particular case didn't have it, but hemorrhage, if you see it, it is pretty suggestive of HSV encephalitis. And then enhancement can also be there. It could be either gyroform or leptomeningeo. This particular case doesn't have much in the way of true enhancement, but you can see that enhancement is something of HSV encephalitis as well. Now, similar to HSV encephalitis, but clinically quite different, is this autoimmune encephalitis, with the most common pattern of it being the limbic encephalitis pattern. The distribution of findings in this entity is going to be very similar to HSV. You're still going to have your mediotemporal, your insural involvement. However, there's not going to be any diffusion restriction, there's not going to be any hemorrhage. And clinically, it's going to be very much different. HSV is a fulminant acute illness, while autoimmune encephalitis is sort of more of a subacute and not very that fulminant illness. Here's a simulated example. Again, I didn't have a good case of it, but this simulated example shows hyperintensity sort of medially in the temporal lobe, some hyperintensity in the insular cortices, and this can be asymmetric from side to side. It's not necessarily going to be symmetric. Now, next disease we talk about is going to be Susac syndrome, and this is a disease commonly mistaken for MS, but it's actually not a demyelinating disease at all. It's an endotheliopathy. Clinically, what's to be aware of with Susac syndrome is this strong association with retinopathy and deafness. So these are the two clues you should look for in your histories. And then, as far as imaging appearance, some of the characteristic findings are going to be these snowball corpus callosum lesions, thought to be pretty classic. These snowball corpus callosum, just shown here in this simulated case, are going to be these kind of swollen, beefy lesions in the corpus callosum. They're going to be pretty homogeneous, and the DWI positivity is another hallmark of the lesions in Susac syndrome. Again, it's an endotheliopathy, so it kind of makes sense that they will be DWI positive, as again shown in this simulated case here with the DWI being positive. And DWI positivity tends to be much more homogeneous and uniform, unlike MS, where the DWI positivity, if there is one, tends to be peripheral and discontiguous, pretty much like their enhancement. Susac is going to be much more homogeneous. So here's a case of most likely Susac syndrome that I had from my case files. Here, not quite as beefy of corpus callosum lesions. You can see here, this is a corpus callosum lesion there. It's got diffusion positivity and restricted on diffusion on ADC. A couple other lesions here, they all tend to be high on diffusion. So diffusion restriction tends to be a pretty sort of central feature of cases, and that's what you see a lot of times with Susac syndrome. Having diffusion positive lesions is sort of a characteristic aspect of Susac syndrome. Here, there's some involvement of the corpus callosum, as you can see, but this particular lesion, obviously not that's typical snowball type of lesion. If you're wondering what these things are, this flare was obtained after IV contrast administration. So this is what leptomeningeo enhancement would look like on flare. These particular areas are all leptomeningeo enhancement. So you can see leptomeningeo enhancement in Susac syndrome as well. In fact, as an aside, the most sensitive MR modality for detection of leptomeningeo enhancement is actually post-contrast flare, not post-contrast T1, and that's why a lot of times you do these post-contrast, these flares post-contrast, because they're much more sensitive for leptomeningeo enhancement detection. And next, we'll talk about posterior reversible encephalopathy syndrome, or PRES. It's important to note that PRES isn't really always posterior in its prominence or always reversible, but that's the name for it. PRES basically is a condition, symptoms of which could be encephalopathy, seizure, headaches, to much more rarely focal neurologic deficits. The pathophysiology of PRES is kind of unclear, but it's thought to be due to disrupted autoregulation, and you can probably fill lectures just on what the pathophysiology of PRES really is. The thing to know about PRES clinically that's very important are its many associations. In particular, PRES can occur in the setting of hypertension, eclampsia, and immunosuppression being the most common, but really lots of conditions have been associated with PRES, and in lots of settings PRES can occur, and these are some of the other things, and you can always do a quick Google search when the time arises, PRES associations to see what the exact associations are. Here's one case of press. You can see you typically get these juxtacortical hyperintensities and also cortical hyperintensities. Typically posterior predominance, hence the name, particularly involving the parietal lobes as well as the occipital lobes. Summarizing the findings of press on imaging, main thing is the juxtacortical hyperintensity and swelling. So juxtacortical meaning the immediate white matter beneath the cortex, so affecting those U fibers, as well as the cortex really is also going to be hyperintense in press, and there'll be swelling. It's a swollen condition. It's important to note that about 10% of the time, press can restrict diffusion, and 10% of the time, press can actually mildly enhance. So here's a case of press. You have this juxtacortical hyperintensities. Clearly, there's hyperintensity in the immediate white matter next to the cortex, and the cortex itself is also probably hyperintense, and the affected parts of the brain look kind of swollen. The involvement, is more posterior predominant, and in particular, parietal and occipital lobes involvement is pretty characteristic. Now, that's not to say that in cases of press, it's always going to be that the parietal and occipital involvement is the most prominent area of involvement, but in almost all cases of press, there will be some involvement of the parietal and occipital lobes. It could be that it's not the most prominent part of the abnormalities. Like there could be the most abnormal findings would be in the cerebellum, for instance, or the frontal lobe or something. But the parietal and occipital lobe typically will have at least some involvement. And this particular case is a tiny trace enhancement in the affected areas, but no true diffusion restriction. But do not let restricted diffusion or enhancement completely dissuade you from press. If you see something that's otherwise good for press, but it has some enhancement or diffusion restriction, press should still be in your differential diagnosis. The one thing about press is it's typically relatively symmetric. I mean, there's some asymmetry you can see, but kind of relatively symmetric. And it tends to be more widespread than something like PML, for instance, because PML is also, going to be confluent juxtacortical hyperintensity, but PML tends to be quite asymmetric versus press, much more symmetric appearance. And press compared to PML would probably have much more swelling compared to PML. PML very traditionally no swelling involved. All right, now let's shift gears a little bit and talk about toxic metabolic etiologies. To get us started, we'll talk about inhaled opioids. Now, inhaled hearing in particular is what's sometimes referred to as chasing the dragon, and it can result in some pretty impressive imaging appearance. One of the hallmark features is this kind of butterfly wing appearance, which consists of symmetric white matter hyperintensity in the cerebellar white matter, mimicking the appearance of a butterfly wing. Other findings you can see in this would be a pretty prominent hyperintensity involving the posterior limbs of the internal capsule, extending into the posterior cerebral white matter. Now, when this condition tends to be severe, it can actually extend to being this confluent hyperintensity in the cerebral white matter and involving the corpus callosum. Here's a case that I came across. You can see much more widespread hyperintensities throughout the white matter. There's still some cerebellar hyperintensities. It's not quite that butterfly wing appearance, a little bit more nonspecific, but quite substantial hyperintensity also in the cerebellum. This particular case happens to show that, as is typical of these toxic metabolic conditions, you can have diffusion restriction with them. So if you see, again, diffusion restriction being a very prominent feature of a white matter abnormality or white matter disease case, toxic metabolic etiologies are a good thing to consider, especially if they're symmetric and pretty confluent and sort of remarkable in their appearance. Here's another case of sort of chasing the dragon or inhaled opioid that's pretty severe. You see here, sort of that butterfly wing hyperintensity involving the cerebellar white matters, but very confluent hyperintensity throughout the cerebral white matter, as you can see here. This particular case does not show diffusion restriction, so it's not an absolute requirement for toxic metabolic etiologies to restrict diffusion, but that's something that you can see with the toxic metabolic etiologies. It could be a timing dependent thing. I'm not entirely sure when this MRI was done as compared to the insult, but the hyperintensity is quite characteristic of sort of this chasing the dragon appearance. or other toxic metabolic etiologies. Next, we'll talk about the sequela of whole brain radiation therapy. Now, whole brain radiation therapy is again going to look very much similar to sequela of chronic microvascular ischemia, except it's going to have a very strong temporal correlation to when there was whole brain radiation therapy. So you can see confluent periventricular and subcortical white matter hyperintensity that can be pretty impressive. And so, for all intents and purposes, it would look like very severe chronic microvascular ischemia, except you would have this patient be sort of younger perhaps, and before radiation therapy would have no hyperintensity, and within a year or two of starting radiation therapy you would have hyperintensity like this, and that would be the sequela of whole brain radiation therapy. A lot of times you can see these microhemorrhages. This is not the most fragrant case of that, but you can see these microhemorrhages like here, here, there, and there. But you can get a lot more impressive microhemorrhages in some other cases. This other entity that's very rare. I've never come across this entity, but just put it here so that you're aware of it. Is this mineralizing microangiopathy? You can get this condition years after radiation, and you develop these calcifications in the basal ganglia and subcortical white matter. I don't have a case of it, but if you are interested, you can look at this case from Radiopedia to train your eye on what this might look like. Right. Next, we'll talk about chemotherapy-related toxic metabolic changes in the brain. Classically, a lot of times you talk about chemotherapy-related white matter changes with methotrexate, but it can be with a lot of chemotherapies. Typically, you have, again, confluent or scattered periventricular and subcortical white matter hyperintensities. And in the acute setting, these actually can restrict diffusion, and in fact, they can show up best on diffusion images. Here's one case of sort of methotrexate-related hyperintensity, very confluent periventricular and subcortical white matter hyperintensity in this particular case. Here's another case. On FLAIR, you really don't see much, but on diffusion-weighted images, you can see these sort of scattered areas of subcortical diffusion restriction that were as a result of methotrexate. These occurred in the setting of, I believe, intrathecal methotrexate in this particular case. So again, to diagnose these, you need to have that history of the chemotherapy, particularly methotrexate, and you need to have, the subcortical periventricular white matter hyperintensities, and if they're very acute, you would have diffusion restriction, and they'll in fact show up best on diffusion weighted imaging. Now I'll talk a little bit about carbon monoxide poisoning. Now the classic finding of carbon monoxide poisoning is bilateral symmetric globus pallidus abnormality, and it's not really typically thought of as a white matter disorder, but the reason I bring it up here is that a third of these patients end up developing what's called delayed posthypoxic leukoencephalopathy that can very much mimic white matter diseases, and this consists of very extensive symmetric confluent white matter hyperintensity, as we'll see. So here's what that delayed post-hypoxic ischemic leukoencephalopathy can look like. So basically, you'll have an initial insult that's hypoxic or ischemic. It could be anything from cardiac arrest, carbon monoxide poisoning, etc. Anything that's hypoxic or ischemic insult. And then 1 to 4 weeks after that initial event, then you develop this very symmetric periventricular and deep white matter hyperintensities. They tend to be confluent, but can also be scattered, but they'll be pretty symmetric because this is going to be a systemic type of a problem. And they tend to diffusion restrict, but the extent of the DWI abnormality could be smaller than the T2 and flare hyperintensity. So here's a case of that I came across during my training. It's a little bit of a busier case, so you got to bear with me. This particular individual, as pretty obvious, had some kind of a big trauma. You can see a depressed paratemporal skull fracture. At some point develop a bunch of infarct. That's what this gyroform sort of high DWI signal you can see in the cortex. That's sort of perhaps starting to pseudo-normalize on the ADC, although still some diffusion restriction remains. Although, as you can see here, some of them, they're sort of really normalizing, and they're already got some swelling, so consistent with like a subacute course of the ischemia and the infarcts. So that was this person's initial event. And then now this is 1 to 4 weeks later, and now has this sort of more vague, you can see this T2 hyperintensity within the deep white matter, looks very different than the areas of infarction, right? But it's got very profound diffusion restriction compared to the areas of ischemia, like the original insult that the diffusion abnormality is starting to pseudo-normalize on ADC, these things are profoundly restricting this white matter signal change, and the character of them on the T2 and FLAIR is also very different from those areas of infarction. So this is precisely what this condition of post-hypoxic, post-ischemic leukoencephalopathy looks like. You have that initial ischemic event, which in this case was the trauma and these multifocal areas of infarction, and then a couple weeks later you develop this very confluent white matter hyperintensity that has diffusion restriction. Shifting gears a little bit, an increasingly recognized source of white matter abnormalities are genetic etiologies, particularly in the adult population. These are your adult onset leukodystrophies as well as adult onset genetic leukoencephalopathies. Now, we don't have enough time to be talking about these. Because there's just so many of them and they're so heterogeneous, but some of the things that can make you think of these would be very impressive white matter hyperintensities that are very symmetric. If you see something that looks like a highly aggressive microvascular pattern of white matter hyperintensity for age, if you have symmetric hyperintensity but with an unusual pattern, like if it's really posterior predominant or something like that, you can think of these genetic conditions. If you have extensive vacuolation, like you can see in this particular case, a lot of flare hypointensity within areas of flare hyperintensity. Again, if you recall from our MS section, you can see this in MS as well, but that you can sometimes see it with adult onset leukodystrophies and leukoencephalopathies as well. So that's something that makes you consider these as well. And then if you have a lot of extensive brainstem findings, like this particular case, if you scroll down, you can see the extensive brainstem abnormalities here. And if you have marked cord volume loss, you can see how tiny this cord is in this particular case, and you have long tract specific signal changes. And I'll talk a little bit more about these in my spinal cord lecture, but those are some of the things you can should make you think of these adult onset leukodystrophies or genetic leukoencephalopathies. So I'm going to spend some time and talk about CADASIL because it's the most common of the genetic white matter disorders. So obviously CADASIL stands for cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. It's caused by mutations in this Notch3 gene 90% of the time. The clinical presentation in CADASIL can sort of vary. Sometimes it can present with ischemic episodes. Typically tend to be lacunar infarcts, seen in about 85% of the times, and median onset being 51 years of age. So it's truly an adult onset disease. When I say ischemic episode, these are clinical ischemic episode, not just lacunar infarcts that you can see on imaging, but a clinically evident infarct with focal neurologic deficits, not just asymptomatic infarcts. Now, other ways they can present at earlier stages would be migraines, which are seen in 50% of the time, with median onset of 30 years, with cognitive deficits, or with psychiatric disturbances, even as presentation. As far as imaging findings of CADASIL, the classic description of CADASIL is going to be white matter hyperintensities, particularly with involvement of the external capsule, like here, for instance, here, right there, and right there, as well as the anterior temporal lobes, like here, and the lesser extent here on this side. So this is sort of the classic finding. It's not entirely specific, very aggressive. Chronic microvascular ischemic change can also involve the external capsule as well as the anterior temporal lobe, but more rare, especially the anterior temporal lobe involvement is more rare with aggressive chronic microvascular ischemic change, but it's not entirely specific. And what makes it sort of specific for CADASIL would be the age at which these occur, in which case with CADASIL patients, they'll have it at much earlier ages compared to chronic microvascular ischemia. Other hallmark features of CADASIL are the presence of lacunar infarcts. You typically see them in the basal ganglia, like for instance these things, with the thalami, for instance this. You can see them in the brainstem, and also you can see them in the frontoparietal white matter. Here are some lacunar infarcts in the white matter, as you can see. Another reasonably common feature of CADASIL are the presence of these chronic microhemorrhages that you can see in up to half of the cases. These microhemorrhages, as you can see here, best seen on SWI images. You can see them in the thalami, the basal ganglia, as well as also in the cortical-subcortical junction. That's a little bit different from the lacunar infarct. The lacunar infarcts are mostly in the deep white matter versus the chronic microhemorrhages will be at the cortical-subcortical junction. Now, the presence of these microhemorrhages, if present, are important sort of prognostic factors, and they're associated with increased risks of stroke, increased risks of hypertension, volume of lacunar infarct, and are also an independent association with increased risk of disability. So this was just a brief overview of CADASIL as the most common of the genetic white matter disorders. Obviously, I actually have two lectures that I used to give to residents on these genetic white matter disorders, and so they can be their own lecture. And if you want more details, I put a couple of links here. So the radiographics article is great. It's got lots of nice images to go through some of the more common genetic white matter disorders, as well as the leukodystrophies, as well as the leukoencephalopathies. And the brain article I like because it's actually sort of a more rigorous sort of scientific paper. They have a big data set of these genetic white matter disorders, and they sort of systematically go over, enumerate what the final diagnosis tend to be, and they even describe sort of a pattern-based approach for when you encounter these, a pattern-based imaging approach for trying to characterize and classify them. So if you're interested in more detail, check out these two links. And it's good, especially if you're going into neuro, to at some point get yourself familiar with these adult onset genetic white matter disorders. Now we'll talk about some of the mimics of white matter disorder. These are all going to be tumors, but because of their appearance, they can mimic something sort of non-neoplastic, like a white matter disorder. So here's a case of what turned out to be lymphoma. You can see at initial presentation, you had a bunch of hyperintensities, sort of oval shaped. Diffusion restriction was a very prominent aspect of these lesions. You can see here the over the corpus callosum with restricted diffusion, here in the deep white matter, maybe a little bit of diffusion restriction there. You can see here again that corpus callosum lesion, another hyperintensity here. Not a lot of enhancement associated with those. There was another lesion in the medulla that was diffusion restricting and perhaps a little bit of enhancement. When I first saw this case, to me, it was a good look for Susac syndrome. And if you remember, the Susac syndrome, diffusion restriction was supposed to be a pretty common feature, and involvement of the corpus callosum also. So I think this sort of fit for me with Susac syndrome or some other vasculopathy, just because Susac syndrome is an endotheliopathy, and you see these lesions with diffusion restriction, you would think something, some vasculopathy or vasculitis. The fact that this turned out to be lymphoma was pretty surprising to me, but we'll see the follow-up on the next slide. So here's that case at a 5-month follow-up. You can see now this patient has developed a clear enhancing mass in the cerebropeduncle with homogeneous diffusion restriction and substantial surrounding vasogenic edema, as you can see here on the FLAIR image. So now the main imaging differential diagnosis here would be lymphoma with these features, and that's exactly what this turned out to be. Now this patient probably always had lymphoma, those sort of more nondescript diffusion restricting lesions on the prior slice were probably all lymphoma involvements as well. One thing to know with lymphoma, and that's what makes lymphoma pretty sneaky, is that if you originally mistake it for something inflammatory and you treat these patients with steroids, the lymphoma can actually respond and it can sort of briefly get a little bit better. And you should not mistake that as confirmation that in fact you are dealing with an inflammatory condition because you treated it with steroid and it got a little bit better. Like this particular case here, I don't know if this patient was treated with steroid or not, but some of the hyperintensity here in the deep white matter has remained the same, but that corpus callosal hyperintensity has sort of gone away. So perhaps this patient was in fact treated with steroids and then it just responded briefly, but subsequently the lymphoma obviously progressed. The steroid is never enough to treat the lymphoma, so they will progress unless you treat them with actual lymphoma regimens. Now, speaking of lymphoma, there is a very rare subtype of lymphoma called intravascular lymphoma that's also a big mimic of white matter disorders. So it's a very rare subtype, and what characterizes this pathologically is that these lymphoma cells are proliferating only within small blood vessel lumens. There'll be no mass like tumors, there'll be no lymph nodes that are enlarged or involved by lymphoma cells, and they won't be detected in the peripheral blood either, these cells, because these cells are only in those distal small blood vessels, not in the bigger veins that you use in your phlebotomy and things like that. And there's a propensity for this form of lymphoma to involve the central nervous system and skin. So sometimes to diagnose it, people do random skin biopsies, but these can be very challenging to diagnose just because there's no lymph nodes to go after or anything. So the article I referenced on the slice below had 11 cases of these intravascular lymphomas, and they came up with 4 or 5 different types of lesions or imaging appearances these things can have. Now, every time you have like 11 cases and come up with 4 or 5 different patterns, you just know that that means that the condition is pretty heterogeneous, and that's exactly what intravascular lymphoma is. It's pretty heterogeneous. So you can have these things. Some of the things they saw was infarct-like lesion, non-specific white matter lesion, meningeal enhancement, and microhemorrhage. Here's a pathologically proven case of intravascular lymphoma that I had. Here on SWI images, you can see some microhemorrhages. So that sort of goes with the microhemorrhage. On the diffusion weighted images, some areas of high DWI signal. Not all, some of them are T2 shine through for sure, but some of them may have a little bit of restricted diffusion, so infarct-like lesions you can see. And then obviously you have the non-specific white matter lesions. You can see some subcortical white matter hyperintensities here, and they do demonstrate some enhancement. A lot of them demonstrate these enhancement. So very heterogeneous appearance would look like it just looks like something inflammatory. You wouldn't be wrong in thinking it's some sort of inflammatory condition. In fact, some of the lesions would be good for something like ADEM, and then with the presence of this hemorrhage, perhaps this is that AHL or Hirsch disease, the hemorrhagic form of ADEM. And that's sort of clinically what this was taught to be for a while. This was like the Hirsch disease or hemorrhagic ADEM, but obviously it's ended up being diagnosed with intravascular lymphoma. The last mimic we'll talk about is the gliomatosis cerebri growth pattern. So the gliomatosis cerebri growth pattern refers to gliomas that grow in a certain way in which they have confluent areas of abnormal signal and involve 3 or more lobes of the brain. And I'll show you a couple examples of how these can mimic just non-neoplastic white matter diseases. So here's one really sneaky case of gliomatosis cerebri growth pattern. Here you can see a case, as you can see in the top left image, had white matter hyperintensity, cortical and juxtacortical involving the medial temporal lobe, involving the insula, some of the operculum, as well as some of the frontal lobe here on the right side, a little bit of the cingulate gyrus maybe on the left. Not much of enhancement of any of these areas of signal change. Now, if you thought this imaging appearance looks just like what I told you for autoimmune limbic encephalitis, I think you'd be correct. I think this is perfect look for autoimmune limbic encephalitis, except that this patient, presented a month later. Some of these hyperintensities were worse, and then there was all of a sudden enhancement in a very characteristic of a GBM. And so this patient had biopsy proven to be aggressive glioma and in a gliomatosis cerebri growth pattern. I really don't think there's any way anyone could know that this was not autoimmune limbic encephalitis just by looking at the imaging. So this is one of those very bad mimic cases, and I think it's just a shortcoming of imaging. We just can't sometimes distinguish these neoplasms from our inflammatory conditions. Here's another case of a glioma. In this particular case, it's sort of more asymmetric. Here you can see you have hyperintensity involving the frontoparietal lobes, and it sort of appears to be have a propensity for extension along white matters here in the sort of white matter where you would expect the corpus sort of corticospinal tract to be going along the internal capsule with some hyperintensity involving the insula as well as anterior temporal lobe, and some of the hyperintensity also extending here to the across the corpus callosum. Again, maybe very minimal enhancement here, and then here maybe a little bit of mass-like nature to the corpus callosal signal change, but really not too much mass effect even with these areas of signal change, honestly. So this was another case that, upon more careful history taking, it was discovered that the symptoms were actually sort of progressive over a month and not really acute problem, because initially it was thought that the symptoms were also acute, so this fit more with some kind of weird inflammatory condition. But once you take a better history, you discover that these symptoms were sort of more expanding subacute and over month. Then the patient eventually had biopsy, and with a relatively high grade glioma against diagnosed in this case also. Again, very difficult to prospectively make the case that this is something neoplastic, but sometimes it's just very difficult to distinguish these things. All right, so we went over a lot of different etiologies in this lecture, so we'll do a quick review. So we talked about chronic microvascular ischemia. What you need to remember about chronic microvascular ischemia is that these lesions are going to be periventricular and subcortical, like shown here. And if they happen in the brainstem, they're going to be central and they're going to be very symmetric within the pons. They're not going to be asymmetric or rounded lesions. We talked about MS, the most common of the demyelinating conditions, and what you need to remember about MS is the McDonald criteria, and in particular in the brain, the definition of the regions of involvement, which are periventricular, juxtacortical, and infertentorial. Periventricular means it touches the lateral ventricle, as shown here. Juxtacortical means it touches the cortex, as shown here. And infertentorial means it's part of the brainstem or cerebellum, as shown with these lesions here. We talked about tumefactive demyelination. These are the larger demyelinating lesions that can sometimes mimic a tumor. And the key things to remember about those are these incomplete ring pattern of enhancement and the fact that they will have very little edema or mass effect given their size. Like if you had a tumor of this size, there'll be a lot of vasogenic edema and mass effect, versus this demyelinating lesion is pretty much not causing any mass effect or edema. We talked about NMO, and we talked that the characteristic features are going to be your long segment myelitis as well as your optic neuritis. However, you can have lesions in the brain, and the key features of those lesions in the brain are going to be that they're going to be periependymal, around the ependymal linings of the ventricular system, or involve the area postremia. Here we have involvement of the area postremia, and periependymal around the fourth ventricle. We talked about MOGAD. Now, a unique thing about MOGAD is this high frequency of bilateral optic neuritis, but there can also be involvement in the brain, and these lesions, when they happen in the brain, they tend to be juxtacortical to encephalopathic pattern, can have involvement of the brain stem, and the lesions tend to be sort of fluffy appearing, not going to be that discrete lesions like MS. And one somewhat unique feature with the MOGAD lesions that they can completely disappear on follow-up. In MS, in things like MS, you're going to have a lesion, it's going to get smaller, but it's never going to completely disappear. But with MOGAD, they literally can completely disappear. Finally, we talked about ADEM. ADEM is what's hallmark of ADEM is that it's a monophasic illness. So unlike, if you see them on imaging, all of the lesions are going to be enhancing, or all of them are going to be non-enhancing. They're not going to be some enhancing, some non-enhancing. And they're going to be typically these large, poorly defined lesions as compared to MS. So we talked about PML and the imaging features to know about PML is it's going to be these confluent white matter hyperintensities that are going to involve the U fibers that are going to be juxtacortical, and they will have little mass effect compared to their size, as you can see here. We talked about HIV encephalopathy or AIDS dementia complex. Again, these are going to be very similar to chronic microvascular ischemia. They're going to be chronic, periventricular, and subcortical, and they will spare the juxtacortical white matter. The only thing that distinguishes these from chronic microvascular ischemia is really age of the patients and the HIV history. And we talked about viral encephalitis, including specifically the HSV encephalitis. These lesions tend to be cortical and juxtacortical lesion, involve the limbic system, classically the medial temporal lobes, your insula, cingulate, gyrus, medial frontal lobe. They tend to be positive on DWI and they can have hemorrhage, and clinically they'll be very fulminant in their time course, very aggressive, present with seizures. This is in contrast with limbic encephalitis, which is going to be very similar in its distribution to HSV, except it's not going to have hemorrhage or DWI signal, and it's not going to clinically be a fulminant illness. We talked about Susac syndrome, which is an endotheliopathy, and it's going to be a lot of times mimics MS. But some of the hallmark features of Susac are going to be this clinical association with deafness and retinopathy, as well as the presence of these beefy snowball corpus callosal lesions that tend to be DWI positive. So if you see a lot of a hallmark of your case being DWI positivity in your lesions, think of Susac syndrome. Finally, we talked about press and imaging features in press are things like cortical and juxtacortical hyperintensity. So you involve the cortex and the juxtacortical white matter. There is almost always going to be parietal occipital involvement, although that involvement might not be the most impressive part of involvement. But if you look closely, you will see some involvement, at least in the parietal occipital regions, and there will be swelling in the setting of press. And again, 10% of the cases, if you recall, can enhance and 10% might diffusion restrict. We talked about a number of toxic metabolic white matter disorders, and some of the common features being that you'll have these symmetric, confluent, periventricular and subcortical white matter hyperintensities, and in the acute setting, these things can diffusion restrict. We talked very briefly and incompletely about adult onset genetic white matter disorders, which are the leukodystrophies and genetic leukoencephalopathies. Sometimes when you some of the times when you can sort of consider these is you see something that's very aggressive microvascular ischemic change for age, as you can see in CADASIL. You see something unusual like posterior predominance, you'll see vaculations, or you see big time posterior fossa, sort of brainstem cerebellum involvement, or very big sort of cord atrophy. As you can see here, this cord is like so thin. We talked about mimics, including lymphoma and intravascular lymphoma. Intravascular lymphoma obviously can mimic, uh, you know, almost completely a white matter disorder, just because with intravascular lymphoma, the lymphoma cells are in those distal small vessels. They can mimic infarcts, they can mimic non-specific white matter lesions, etc. Even traditional classic lymphoma, histopathologic classic lymphoma, can also sort of mimic something like Susac syndrome. And the learning point here is if you see a case where the dominant feature is diffusion restriction, no matter how nondescript and non-mass-like, keeping lymphoma in your mind is probably a good idea, and having very short-term follow-up also a very good idea. Remember that lymphoma can respond to steroid therapy, so just because it improves a little bit with steroid therapy does not mean it's not lymphoma. Keep that in mind. Finally, we talked about the gliomatosis cerebri growth pattern. That's when you have a signal abnormality with expansion involving 3 or more lobes in the setting of a glial lesion, glial neoplasm, sorry. And for all intents and purposes, these can be extremely difficult to distinguish from just inflammatory or autoimmune white matter disorders. We showed a case where it was pretty much identical to autoimmune encephalitis, and this other case that was sort of more asymmetric and unilateral, sort of having a big white matter propensity for extension along white matter tracts, but not with a lot of swelling or mass-like nature, but also turned out to be glioma. So I hope you enjoyed this lecture, and after you're done watching this lecture, go ahead and watch the spinal cord lecture, because spinal cord is really, assessing the spinal cord is really a complementary part of assessing white matter disorders.